Welcome to 3 Steps to Defeat Amputation, Assess, Screen, and Report. My name is Beverly Tomasian. My pronouns are she, her, and hers. And this is a topic I am very passionate about. I work at Indian Health Services 1 day a week, and any person coming in to see me with a diabetes that I haven't met before, we're going to take off shoes and socks and look at feet. And sometimes people are a little bit hesitant to share their lower extremities, and I get that. It can be a little bit, nerve-wracking because it's unusual to have somebody look at your feet so closely, but it can really make a big difference in outcomes and providing education and strategies to prevent foot problems. It is so worth our while. And I want to say something else really important. No matter your profession, everyone can look at feet, because we may not know exactly what to do. And that's me too. Sometimes I'll look at a foot, and I'm perplexed. I'm like, something's not quite right. But that something is not quite right, understanding and acknowledgement, and then as a healthcare professional, you're relaying this information to the provider, can make a difference between saving a limb and losing a limb. And I know that sounds big, but it's actually really accurate. And the rate of amputation is not decreasing, it's increasing. So each one of us can make a difference in defeating amputation. Each one of us can take steps to protect lower extremities. I'm so glad you're here. I always kick off my programs with a land acknowledgement. We acknowledge and are mindful that Diabetes Education Services stands on lands that were originally occupied by the first people of this area, the Mechoopda, and we recognize their distinctive spiritual relationship with this land, the flora, the fauna, and the waters that run through this area. We're excited to share with you that we have 2 amazing individuals who are helping run this company and provide the best service possible to each one of you. Brianna and Tiffany are both dedicated to customer advocacy and customer happiness. They are very knowledgeable also about the steps to gain certification, so they can help walk you through the steps or help locate different things on our online on our website, which there's so much information on our website. We've tried to simplify it a lot, but one place you might want to check out when you're looking for information is we have a tab that says free. And on that free tab, we have a lot of great information, including handouts in English and Spanish regarding foot care education. They're free. And we believe in our content so much, and we believe in helping improve the lives of people with diabetes, that we want to provide the resources and tools that you need. I just want to say Christy is listening in. I just want to give her a shout out. And here's our inclusion statement. We are committed to promoting diversity and inclusion in our educational offerings. Our goal is to promote equity and access, and we recognize and respect and include differences in ability, age, culture, ethnicity, gender identity, sexual orientation, size, and socioeconomic characteristics. We try to weave that throughout our course content, especially with a big focus on social determinants of health and how they can impact people's ability to self-manage their diabetes and take action. I want to say that I have no conflict of interest to report to y'all. Okay, so what are our objectives for today? Look at those beautiful feet. We're going to describe the risk factors for lower extremity complications. We'll look at prevention strategies. We'll demonstrate the steps involved in lower extremity assessment, and we'll review actions we can all take, regardless of our profession, to protect and identify lower extremities that are at higher risk. Now, where did I get this information from? Well, there is a pocket examination chart that is printed by the American Diabetes Association. It has a lot of good information to provide a comprehensive foot exam. I found a great article in Family Practice, How to Do a 3-Minute Diabetes Foot Exam, that was really helpful for people who don't specialize in diabetes and are not podiatrists, for what to look for and how to do it quickly. We're all busy. This is a comprehensive foot exam and risk assessment. This was published a few years ago, and it's a report of the task force with collaboration with the American Diabetes Association and American Association of Clinical Endocrinologists, and of course, our ADA standards of care. Standard 12 talks about eye, nerve, and lower extremity issues. So there's a lot of information from different sources. And I do want to acknowledge that lower extremity care is complex. And I'm saying that identifying when something isn't right is, pretty straightforward, but there's so many factors that contribute to lower extremity disease that we'll be discussing today. And the other thing I want to say is I put real live photos of lower extremities that I've encountered or others have encountered. And some of these images may be difficult to view. So I just want to say that out loud. But, after a while, I've looked at so many feet that I have kind of learned to understand what the foot is trying to say. And I know it sounds a little woo-woo, but there's a lot of validity in that, because the foot is going to give us, through our visual inspection, information about issues that are not working for that foot and issues that really deserve our attention. So what about diabetes and amputations? If you ask a group of people living with diabetes, and when you teach group classes, you might want to say, what is the thing you're most worried about with your diabetes? And many times amputation and dialysis are two things that I hear consistently. What is the rate of amputation? Do most people with diabetes get amputations? No. It's really important for people to know. It is unusual, but it can happen. So the rate of amputations declined from 2000 to 2009, but then we saw this uptick from 2009 to 2015, and it's still been steadily increasing. But look, if you look at 1,000 people living with diabetes, only 2.1 of them, now it's doubled to 4.2 per 1,000 will have an amputation. And when I say amputation, I'm not just talking below knee amputation. It could be a toe or a partial foot amputation. So when you see these statistics, keep that in mind. It includes all types of amputation. 62% is the increase is driven by increase in minor amputations, the toes. Now, this is really upsetting. The highest rates are in young and middle-aged adults, 18 to 64. Usually, we would see it occurring in older adults. So these are adults we would consider that it's occurring in their working years, and it can really impact economics of that individual and our society. And you can see here 130,000 adults annually with diabetes have lower extremity amputations. Relative to I think it's 14 million people that live with diabetes in the US, that is a pretty small number. So and I'm not saying that these 130,000 persons that have amputations, I recognize, how difficult that is. But if we look at it from a population standpoint, it is uncommon. So 5 out of every 1,000 people with diabetes might have an amputation in their lifetime. Now, there's a lot of health disparities when it comes to risk of lower extremity amputations. And this is Dr. Faluso Fakaridi, the only cardiologist in Bolivar County, Mississippi. And he is a cardiologist, but he was doing research seeing that there were so many amputations being done in the South, especially to people of color, to Black Americans. And he wanted to figure out why. And he wanted to move to Mississippi to help out. And he's made a huge difference. Not only is he working in this clinic of talking about amputation prevention, he's spoken before Congress. He's tried to promote legislation to improve care for people in under-resourced communities and people of color to decrease the rates of amputation, because you can see here, Black Americans and people of color have 3 to 4 times the rate of amputation compared to white Americans. And that's really social determinants of health, access to resources, other systemic issues that decrease the amount of care people in these communities receive. Amputations are cheaper than doing revascularization surgery. In many situations, it costs $30,000 to $60,000. More amputations are performed on people of color, and it's associated with earlier death compared to someone who does undergo, vascular evaluation and revascularization. So let me ask you this question. Which of the following factors increase the risk for amputation and diabetes? A, socioeconomic status. B, cigarette smoking. C, previous amputation. D, age and ethnicity. Or E, all of the above. So let me go ahead and launch this poll. See what you all say. And if you haven't been to one of my classes before, please know that whichever answer you choose, it's okay. Because what if you choose the best answer? Great, you get reinforcement of knowledge. What if you choose the wrong answer? That's okay too, because you're still going to learn from that experience. So this is a win-win situation, and it's just really great. We're trying to build these new neural pathways and discover new information. So go ahead and make a commitment knowing that this is a safe place to do that. We're going to really practice kindness to ourselves. Okay. Well, having said all of that, let me close the poll and share that 100% of you chose the best answer. So I'm giving y'all a shout out. Right. It's complicated, right? We know that socioeconomic status and resources, smoking cigarettes increases a risk of peripheral arterial disease, decreases circulation. A person with a previous amputation is more likely to have a future amputation. And we know as we get older in certain groups, Black Americans, people of color have higher rates of amputations. So E, all of the above is the best answer. Now, this came from a government website, and it's talking about risk for amputations. Consider these factors. Region. People who live in the South have highest rates. They also have lowest rates of revascularization. What about race? People who are Black Americans, Hispanic Latinos, American Indians have higher rates of amputation. And then age. Most people who receive amputation are older, but many times the symptoms are attributed to arthritis and gout. And honestly, y'all, I've seen the symptoms attributed to neuropathy. So I'll ask people, hey, when you walk, did your calves hurt? And they're like, no. I'm like, no. Then I know, oh, okay, do your calves hurt at night when you're trying to sleep? Yes, that's neuropathy. But I had one person say to me, my calves don't hurt at night. My calves hurt when I walk. And it just like a light bulb went off. I'm like, oh, you don't have neuropathy. We have to check your vessel disease, your vessels. And sure enough, when I tried to get their pulses, I couldn't find their pulses on either foot. So we referred them right away to their primary care to get referred to a vascular specialist. So, but many times primary care doctors do not know about peripheral arterial disease and may not screen for it, or they may not ask those questions. We can ask the questions and find out, and we can check pulses to see, does this person potentially have PAD, and what can we do to support them? Socioeconomic status. People who have less income and less resources have less access to quality health care and have higher amputation rates. And then what about the hospital volume of vascularization procedures? Well, hospitals are better at preventing amputation if they can assemble a team of specialists who are knowledgeable and proficient in aggressive limb salvage, wound care, nutritional care, diabetes management. In rural areas, we often lack those specialists in those teams. And so you can see in certain populations, in certain regions, the cards are stacked against them. And Dr. Fakaridi is trying to say, let's equalize the playing field. Let's make sure everyone has access to the best care and evaluation of vascular and lower extremity health. So who's at high risk for ulcers and amputations? Well, individuals with elevated glucose, if they have neuropathy, they have nerve damage, so they can't feel their lower extremities, they're at higher risk for foot injury and resulting amputations. Smoking cigarettes, if their foot has an unusual shape and it's putting pressure on certain areas that normally would not have a lot of pressure applied to them on the foot. That can increase the risk. And then if they have pre-ulcerative callus or corn, that has a potential for growth. And then you can see if they have poor circulation. Arterial disease is that poor circulation going to the lower extremities. We have a hard time finding pulses. History of foot ulcer, amputation. What visual impairment? Why would that make a difference? Well, most people, if they have visual impairments or retinopathy, they probably have some degree of neuropathy. But also, if I have visual impairment, I may not be able to see that I've injured my foot, or I might not see well to navigate my household or the outside, and I might be more likely to injure my foot or have a fall. So visual impairment is co-associated with ulceration and higher risk, and then kidney disease. So if people are spilling protein in their urine, and they have kidney disease on dialysis, they oftentimes have neuropathy, retinopathy. So they're at higher risk for nerve damage and associated ulcerations from that. Let me ask you another question. Which of the following is true about diabetes and lower extremities? Over 30% of people with diabetes experience amputation. Over 50% of amputations could be avoided. Most amputations happen before the age of 70. The rate of amputation continues to decrease. Wear white cotton socks. Well, that's an interesting answer, that D. So looks like I am, yeah, not really sure. Oh, I just closed the poll accidentally. Okay. Sometimes I just get super excited and I close the poll accidentally. So we're going to do this one together. But the best answer is B. We know that less than 5% of people with diabetes ever experience amputation. And we know that most amputations happen later. But we're seeing more and more younger people get amputations. That is true, but generally speaking, looking at epidemiologic data, it's usually older age, and the rate of amputations is increasing. Now, this wear white cotton socks, we used to say, hey, everybody wear white cotton socks. Why did we say that? I'm just looking if I have my socks with me. Well, we said that so that we could see if there was any drainage on that sock, and it was easy to identify if they had a wound that was oozing that they didn't know about. But white cotton socks have a major problem, and that is they're pure cotton, so they tend to hold on to moisture. We want more cotton polyester blend that wicks away moisture. The other thing about cotton socks is they have a seam on the top, and that seam can actually rub against the top of their feet and cause ulceration. So if I'm working with individuals with limited income and they're wearing white cotton socks, I'll just say turn them inside out. If they turn them inside out, the seam is facing up and not rubbing on their skin. That can help a lot. But I will recommend trying to get polyester cotton blends like our diabetes socks, which we'll talk about later. But the truth is, as I'm talking, I'm sharing with you all the tips that I'm going to share with people living with diabetes, because we know 50% of amputations could be avoided. The ADA has foot care standards, and what they say is let's perform a comprehensive foot evaluation at least annually. Once a year, look at people's lower extremities, provide general, preventive, foot self-care education to all people, regardless of their foot health status and their lower extremity status. Let's provide some basic education. How do you cut your nails? How do you clean your feet? Let's look in between the toes. Let's talk about shoes. Sensory loss or prior ulceration, we're going to look at their feet every visit. High-risk individuals may need specialized therapeutic footwear. Who's high risk? Well, they have neuropathy, foot deformities, ulcers, callus, poor peripheral circulation, or history of amputation. So we really do risk stratification when it comes to lower extremities, and we want to make sure those at the higher risk are surveilled more frequently. And so my motto is, let's lift the sheets and look at the feet. You can steal that. It's not good grammar, but it's kind of cute. So when we look at this left foot, where this foot in the left picture, it's a right foot actually. When we look at this foot on the left picture here, what do we see? Are you worried about that foot? I'm not. I don't see anything wrong with that foot. I look at it, I see it's clean and dry. The nails are appropriately cut. There's no inflammation. This person, either they're, managing their own toenails or getting a pedicure. Now, as far as pedicures, can people with diabetes get pedicures? It's really individualized. Like if I am my A1C is on target, I'm not immunocompromised for any reason, where I get the pedicure done, they use sterile technique, or not sterile, but they sterilize their instruments would be a better way of saying it. That I would move toward yes. But if I'm working with an individual with elevated A1C who's high risk for infection, we're going to be a lot more cautious. This lower extremity is not swollen. And look at this person can touch their feet, so they're very flexible. We love that. Okay, what about this middle picture? Right away, you can know nothing about lower extremities and know that there's a problem here. So this is edema, right? There's a fluid collecting in the interstitial space. Why is there fluid collecting? Well, it's usually venous disease where the heart is having a hard time receiving the blood back up. So the flow of blood back up to the heart is impeded for some reason. Maybe there's some vascular disease. Maybe this person has fluid overload. So by the time the blood gets to the lower extremities, the fluid leaves the circulation and goes right into the interstitial space. Maybe they have dependent edema. There's could be a lot of different reasons. Maybe they're not taking their Lasix. But this, when I see this, it's an alarm bell immediately. And they're looking to see if there's pitting edema here. So they're seeing how much fluid is in that foot. And the other thing I'm thinking about is, how are they going to get a shoe on there that can accommodate this foot? And I'm just imagining that foot rubbing on the shoe, raising the potential for ulceration. This foot, these lower extremities demand attention of a provider, of somebody who can help take action. What about these lower extremities? All right. Regardless of your profession, all of us could unanimously, immediately agree that these lower extremities are in big trouble. Let's see what we have here. We have a toenail on both sides that is growing over into the skin. Now, why would this happen? Well, maybe this person has vision difficulties. Maybe they can't bend over to cut their toenails. Maybe they have mobility issues. Maybe they have cognitive issues where they're like, oh, there's something wrong with my toenails. They can't even evaluate them for themselves. When we see this, maybe they have fungus, and their toenails are so thick, there's no way they're going to cut. So I don't see this person is not caring. I see a whole different picture of, man, what can we do to support this person, because they need support bad. You can see the calluses on the bottom of their foot right here, of their feet. And those calluses can be very hard, like having rocks in your shoes, and they can damage the soft tissue underneath. I mean, it looks like there might be some hammer toes. The toes are definitely not laying flat and straight. And I'm going to look in between these toes, because in between toes is where we can evaluate to see if I'll tell you the fancy term, interdigit maceration, where dead skin builds up and bacteria, and it can lead to ulcerations. And I'm going to use all my senses. I'm going to be using my, visual senses. I'm going to be touching. I'm going to be smelling. I'm going to be, well, I'm not using all of my senses. I'm using 3 of them. And I'm going to be evaluating what's happening here. And when I look at the legs, that definitely looks to me like peripheral arterial disease. They're kind of thin, they're shiny. I don't see a lot of hair. I mean, we need more information, but I'm just imagining I'm going to be looking for pulses on the top of their feet and having a really difficult time finding them. Okay, very high risk. Now, I have in my cheat sheet, so this is go to free and then go to cheat sheet page. It's 3 steps to save feet: assess, screen, and report. And this actually is just a sheet that walks you through the steps I'm going to be going over today. So it's a stepwise approach to assessing lower extremities and helping us kind of know what to look for and what to keep track of. Okay, question 1. These are questions we're going to ask the individual and evaluate. Is there a history of foot ulcer, or is there a foot ulcer now? Now, this gentleman came into the hospital and here's his story. He said, well, I was diagnosed with diabetes. My provider wasn't too worried about it. I had a callus on the bottom of my foot. I started to trim the callus with a razor blade. And before I know it, I started bleeding, and then my foot turned red and hot. So he has cellulitis, and this is another common scenario where people have a callus, they want to trim it, they trim away the dead skin, but they start getting toward the new tissue, and they don't know that they're going too deep because they have neuropathy. So now they've opened up their skin to bacteria, and then bacteria have, welcomed this opportunity, because now there's not only flesh, there's blood, and there's sugar in that blood. So it's a perfect medium for bacterial growth. And this gentleman, obviously has a bunion right here too. So there's a lot going on in this foot. But if they have a history of foot ulcer, it increases, or if they have a present foot ulcer, we know they're at increased risk for amputation, immediate action required. And this person, well, we'll see him later what happened. Now, question 3, is there deformity? This person has a deformity, and this is a very common look of a person with diabetes who has nerve disease. They're called clawed foot or with hammer toes. So you can see there's shortening of the tendons, the Achilles, and other tendons that make the foot misshapen. And it's going to put a lot of extra pressure right here on the pad of the foot, on this first metatarsal, and in the center here. And this person has some hammer toes. So it's really like a shortening of the tendons, changing the shape and weight distribution of the foot. And this can lead to ulcerations not only on the pad and heel of the foot, but also on the top of the toes. When we see this foot, this person needs help. And what help do they need? They need to see a podiatrist and a person who makes custom shoes, a podorthist or an orthotist. To make custom shoes to accommodate their feet, they're going to need depth shoes so that it can hold their whole foot and not rub on top. So this is, wow, when you're looking at risk, such a high risk. We're looking at that foot every time. What about foot deformity? Look at this person's second toes. So definitely this hammer toe can rub on the top of the shoe and change the weight distribution of the foot. So we want to look for prominent bony areas, any other bunions, Charcot foot, just this, again, we need help. Now here's Charcot foot, and Charcot foot is pretty rare, but I've seen it in several situations in my clinic setting where a person came in and he actually said to me, oh, I hurt my foot on the tractor. And I go, really? And when I said, let's look at your feet. And when I saw his foot, it looked like this. And what happens is the arch is lost, and pretty soon the foot just collapses like this, and it comes to be a rocker bottom like that, because the bony structure and the tendons have just collapsed. This is due to a combination of nerve damage and circulation issues. And this person, you can see, is developing an ulcer here. And look at the sores, the ulcerations they have on their big toe here and their second toe. So, but this can start with inflammation. The foot might be hot at first, and then it doesn't really hurt, but they notice it's inflamed and hot, and then the bones just start collapsing. So when we found this person in our clinic, we actually casted his foot. And when you cast the foot early on in Charcot, you try to maintain the shape of the foot. So protecting it during that inflammatory state, and then hopefully after we take off the cast, their foot can maintain its shape. So a person with a Charcot foot is permanently risk category 3, and we'll go over that. Now, looking at toenails, again, this is not glamorous, but it's so important. Are their toenails thick or ingrown? Are they kind of breaking off? Does it look like they might have some fungus in their toenails? Like, how did this toenail get to this place? Did this person, are they picking? Some people do have a disorder where they pick their toenails. Do they try to cut it and it just kind of broke? Is this the way their toenails always look? And have they tried any treatment? If we see toenails like this and you ask the person, can you trim your toenails? Or like, they are so thick, there's no way I can get through. If that person tells you they are so thick, I have to use a wire cutter to get through, this is a referral to podiatry. I mean, we want to help prevent this person from cutting their flesh. Thinking about this person again. I mean, look, this person is having a hard time cutting their toes or cutting their toenails, or knowing that their toenails need to be cut. And this gentleman who came in to see me, his toenails are on the longer side, and you could see this toenail here can actually start rubbing on the toe adjacent to it and causing ulcerations. And I asked, are you having trouble cutting your toenails? Yes, they're so thick, they're hard to get through. And when people have thick toenails, it does say here, of course, podiatry referral. But one thing that they can also do in the meantime is put Vaseline on their toenails before they cut them, or cut them after they take a bath. So taking a bath or soaking their feet, for 15 minutes, putting Vaseline on that toenail in addition to that can make them much more soft and pliable and easier to get through with a toenail clipper or a clipping device. But some people, again, they'll use wire cutters or scissors, and that can be really dangerous. We had a gentleman who had ingrown toenails so bad, and he couldn't get in to see the provider. So he went ahead and cut his toenails at a very deep angle because he couldn't make it to the clinic to get the care he needed. So people will try to do the best they can, but sometimes that can lead to problems. So we want to be kind and gentle too. Now this is callus buildup. This person, I don't know them, but I'm thinking this person has neuropathy. They don't feel their feet that good. Their sensation is diminished, and also they're putting unusual amounts of pressure on this part of their foot. And you could see if they just come in like this, you go, oh, it's a callus. But once we trim back that callus, we see that there is an ulceration developing. And this is what happens a lot, because this thick, hard skin is like having a rock in your shoe, and it damages the soft tissue underneath. So that's why calluses really deserve our attention. And again, looking at this person's toenails, to me, that looks like fungus. I mean, this person needs a lot of attention and help, and the intervention of a professional to reduce their risk and protect their feet and address this ulceration. Now, we looked at swelling before, or edema, and what does swelling come from? And we talked about Charcot, where there can be inflammation of the foot temporarily. There could be an infection. So, man, when we look at feet, we're looking for swelling from a recent injury, or if they've done an intervention on their toenails and that got infected, or it could just be venous stasis. And I talked about that earlier, where the blood can get down to the feet, but the blood pools in the feet, so the fluid leaves the blood and it goes into the interstitial space, and that causes that edema. So they might have some venous compromise where the blood has a hard time getting back up to the heart. And maybe this person isn't taking their diuretic, or maybe they need diuretic. Like, there could be a lot of different reasons. But again, we don't have to figure out what's causing it. All we need to know is that this person needs help. Let's make sure their primary care knows about this, and then consider referral, of course, to a specialist. I like that this person with her swollen feet has them elevated. That's great. We want to elevate. Now, elevated skin temperature. This is such an important measure. There are different temperature measurement devices we can use, and those temperature measurement devices are actually predictive of future foot ulcer. But we can also use our hands. And if we just touch both extremities at the same time, and we notice that one is warmer than the other, it's a cause for concern. A temperature elevation of greater than 2 degrees centigrade, or noticeable difference by touch, is considered clinically significant and requires follow-up. Why is one warmer than the other? Is it a circulation issue? Is it an infection issue? What's happening? And is there mechanical stress, a fracture? It requires further investigation. The other thing is muscle weakness. When I meet with people, I'll just say, flex your toes and your feet, make circles with your ankle, seeing if they can do that, or, can they even bend their toes? This is something called a prayer sign, And this is a person I was working with, and he has type 1 diabetes. And this is a sign where the tendons have become glycosylated, and they're so glycosylated that the fingers can't lie flat against each other. Like if you ask me to do the prayer sign, there's no space in between my digits. But in this situation, from chronic glycosylation of the tendons, they become stiffer and they are not able to completely straighten. Now, if they have this prayer sign, and look at how proud I am that he's wearing his diabetes bracelet, great job. If they have this prayer sign, I know that their feet are also going to be stiff. So when you look at these feet, this person has had type 1 for over 30 years. I was doing the monofilament testing on him, and he goes, don't even bother with monofilament testing. I can't feel anything below my ankle. So his feet look waxy. There's no hair on here. When you ask him to move his feet, there's very little motion in his feet or his ankles. But he is so diligent. He checks his feet every day. He wears, clean pair of socks and wears shoes that are supportive. He inspects his feet. He's on top of it, and he's very careful about trimming his toenails. So this individual realizes that I want to do everything I can to protect my feet, and he's very involved in his self-management of his feet. Now, can they see the bottom of their feet? So some people can, bend over, bend their knees, look at the bottom of their feet. Others might have difficulty. But a really important place to look is in between the toes. And I was talking about interdigit maceration. Here's a beautiful example of that, where you can see the skin is starting to peel, revealing the tissue underneath. Now, this can lead to an infection and to an ulceration. And it's a sign to me that that person oftentimes can't reach in between their toes. Maybe they don't have the flexibility. So we'll just talk about using a long handled brush, or having somebody help them clean in between their toes, or, maybe after their bath or shower, cleaning in between their toes, and never applying lotion in between toes. That will increase the maceration and the tissue damage. So this is something we want to look for and coach people on in a very kind of diplomatic way, because it can feel embarrassing to them. The thing about the shoes is, how do they fit? What kind of shoes are they wearing? Are they wearing, tennis shoes? Are they wearing shoes that are Velcroed? Are they wearing high heel pumps? And we want to make sure that the shoes can accommodate their feet. So can they wiggle their feet? And I love looking at people's feet right after they take off their shoes, because you can see if there's any red areas where the shoes are putting too much pressure. One of the, big issues is if the shoes are too tight, that can decrease circulation, increase friction, and lead to ulceration. And if they have any deformities of their foot, we want to definitely make sure they have custom made shoes. So let me ask y'all this question. What is the most common cause of ulcerations of the lower extremity? Is it A, Dr. Scholl's corn pads, B, minor trauma, C, trimming calluses, or D, burns from hot water? Let me launch this. What is the most common cause of ulcers? Dr. Scholl's corn pads, minor trauma, trimming calluses, or burns from hot water? And just take your best guess. All right. Oh, wait, one more second. Thank you. The votes are coming in. Okay, I'm going to close the poll and share your results. So 33% of you said minor trauma. Most of you said trimming calluses. It actually is minor trauma. So trimming calluses, absolutely, especially if that person is, very aggressive, can lead to skin openings and opportunities for bacterial growth. But minor trauma, it's those, like you walk to the car and you burn your foot because you're barefoot, and that can lead to a blister, which can lead to an ulceration. Stepping on a needle or a pen because you're, walking barefoot, wearing shoes that are too tight. Those are all considered minor traumas. And believe it or not, they're one of the biggest contributors to ulcerations. So those little things, and that's why y'all know we say wear shoes at all times. And it can be, I really like Birkenstocks because they have that cork bottom and the strap goes across this way, or those type, that style of shoe. Like if people don't want to wear a tennis shoe or an enclosed shoe, they can choose other open shoes as long as we really try and stay away from flip-flops or things that have that thong that go between the first and second toe. And then we want something that has a pretty decent sole so that if you do step on glass or a nail or something like that, it protects you against that. The thing with people with diabetes, they might step on something and injure their foot and not feel it. That's the big problem. If you don't feel injury, you don't take action. And if you don't look at your feet, you don't know that they're injured if you have neuropathy. So tight shoes and minor trauma are the most common causes of ulceration, especially in the presence of neuropathy and peripheral vascular disease. And these two combined can lead to blood pooling and swelling. The muscles they're just atrophied. And there's deformity and joint stiffness, which we've seen. And then there's more plantar pressure and trauma. You can see just an example of wearing shoes like this. And then I'm like, people need to wear fancy shoes every so often. So let's just get that straight right away. But look at the pressure that's applied. And that's kind of true for a lot of shoes that don't allow your feet to wiggle. They apply that additional pressure that can lead to ulceration. And just something simple like a blister from walking on like hot sand, hot pavement, walking by the pool and it's hot. I had a gal, it was so hot by the pool, but she couldn't feel it. And pretty soon she noticed, oh, what's this coming off my foot? It was her skin. She didn't even know. So little blisters can break the skin, allow for bacteria to come in, and worst case scenario, lead to osteomyelitis or bone infection, which can lead to amputations. So looking at risk factors for peripheral arterial disease, and that means the blood has a hard time getting to the lower extremities. Diabetes, for people over the age of 60, hypertension, hyperlipidemia. For people who smoke, they're at higher risk of peripheral arterial disease. Black Americans, again, have 3 to 4 times increased risk, yet many times there's not enough screening or appropriate screening of lower extremities to help identify peripheral arterial disease and get the care needed. So I just want to go over the symptoms of PAD. Most people don't know these. So gosh, if we can help people just report if they have these signs and symptoms right away. The classic sign, and I've talked about this earlier, is pain in the legs with physical activity. So now that your body's demanding more oxygen, our arteries in the legs can't deliver enough oxygen to the leg muscles because they're not working that good. There's decreased circulation in the arteries. So it causes like an ischemic pain, very uncomfortable. The person will stop. They will stop walking because it hurts so bad, and they'll rest, and then they'll get up and they'll walk again. And then after a while, it will start hurting again. Really great to keep trying to walk if people have PAD because it can build collateral circulation. But 4 in 10 people with PAD have no leg pain. And that's where we come in, looking at pulses and so forth. But the pain can happen not only in the calf, but in the hip, in the thigh, and the buttocks. And this is why we want to do ankle brachial index evaluation. Now, signs of peripheral artery disease: muscle atrophy, hair loss, skin that is cool to touch, decrease of absent pulses, or sores or ulcers in the leg, and that the ulcers don't heal. So this gentleman that we saw earlier who had diabetes and he was trimming his calluses, he has peripheral arterial disease. You can see his leg looks kind of purplish here. He's a smoker. And I tried to find pulses, very poor pulses. So in addition to trimming the callus, he had poor circulation to his lower extremities, which increased his risk. This person ended up getting a partial foot amputation with some basic education. Don't trim calluses. Let us help you. We could have saved that lower extremity. And we know that once a person has a partial foot amputation, they're at higher risk for future ones. when we're looking for PAD, their skin is pale blue or purple. When they hang their feet down from a table, an exam table, they'll get really red. When you lift their feet up, they go like ghostly white, blanching when elevated, like so white, because the arteries aren't like don't have enough pressure to push the blood into the feet when they're elevated. Diminished pulses. So for this person, we want to avoid constriction, keep moving, stop smoking, get ankle brachial index, medications, and surgery. Okay, we're halfway there. Let's do, well, we're a little bit more than halfway there, but let's do a little stretch. I love this picture outdoors. Stretching, rolling our shoulders back. Feels so good. Okay, let's keep going. So vascular status assessment. Let's look at pulses and see where do we find pulses and what do they indicate. So here's our dorsalis pedis artery right here. And how do you find it? Well, you can have the person extend their great toe and you'll see the extensor tendon. So medially to the extensor tendon, you can check for pulses right there. This person has a lot of hair on their toes, so I know they've got good circulation because grass don't grow where water don't flow. So if there's blood flowing, we got hair. So when I see hair on people's toes, I'm like, yay, let's celebrate. Now, when you're touching for pulses, you just don't want to apply too much pressure because you'll obliterate the pulse. You just want to apply gentle pressure using 1 or 2 fingers, not your thumb, and then see if you can find the pulse there. Yeah, you might just have to close your eyes and just wait for a few seconds till you find it. And here's an example of a provider checking for that pulse. Now, the posterior tibial artery, a little harder to find, but it's right behind the ankle bone, medial malleolus, and you can just make a little C shape, reach over like this. Here's a C shape right here. So your thumb is on the outside and your 3 fingers go toward the inside, gently applying pressure to feel that pulse. So those are the 2 lower extremity pulses we evaluate for. And if we can't feel those pulses, we might have to get a Doppler out and see if we can feel those pulses. But it's our first sign this person might have peripheral arterial disease, and that requires further investigation. So refer to multidisciplinary team. If claudication, if they're complaining of that pain in their leg, their calf or buttocks, or we can't find the pulses, if they have foot ulcers, and then foot care specialists recommended for those who smoke, have history of prior extremity complications, lower extremity complications. They have nerve disease, structural abnormalities, or peripheral arterial disease. So these are people that are high on our radar list, especially if they have dialysis or Charcot, nerve disease. And then I just wanted to share with you, how do we get the ankle brachial index? So we check the brachial, we check the pulse over here, the brachial systolic blood pressure. I didn't mean to say pulse. We check the blood pressure and we check it on the right and the left arms. And we just are really interested in the systolic blood pressure. So that top number. So here's their systolic blood pressure. And then we take the highest of the 2. So this person, their left arm has a higher systolic blood pressure. And then we go down to the lower extremities and we test their pressure on the lower extremities, the posterior tibial and the dorsalis pedis. And again, we take the highest systolic blood pressure on this left side and on the right side. Now, this systolic blood pressure from the arm becomes our denominator. And if somebody has great circulation, they will have the same systolic blood pressure on the lower extremity as on the upper extremity. That is the systolic blood pressure, the dorsalis pedis pulse or the posterior tibial would be 160. But you can see the pressure is lower than the arm pressure, which indicates there's peripheral arterial disease. There's not the same amount of pressure on the upper body as the lower body. So just these should match. The systolic pressure should match. We take the arm systolic pressure as a denominator, and then we take from the left and right side, we evaluate, we put their systolic pressure as the numerator to get our ratio. So the ratio here is 0.75. That means there's 1/4 less to circulation on the lower extremity as opposed to the upper extremity. This number honestly should be like 1. That would be a great number. So it gives us really great information about arterial body health and circulation. So you can see if that ratio is 1-to-1, if the systolic pressure is the same in the arm as it is the leg, it's considered normal, 1 to 1.29. Once we start getting below 0.99, then we know, there's less circulation on the bottom extremities. So that's borderline. And then once we start getting lower numbers, less than 0.9, we're moving into mild to moderate disease. And sometimes we might get a really high number, like more than 1.3, and that indicates it's non-compressible. So there's a lot of arterial disease, and that we might need to reinvestigate. So that's just a sign that, do we really do that accurately? Let's check out what's going on. Now, this ABI is simple to do. You do need a Doppler. It doesn't require a vascular surgeon. It just requires a team who knows how to make it happen. We could do it during an office visit, maybe especially have that person come in to evaluate that. And that ABI is so important because it can help us understand this person's risk and if they should be referred to specialists for revascularization, medications, or another procedure. The thing is, when people have diabetes and neuropathy and they have poor circulation, peripheral arterial disease or venous disease, this can lead to big problems because they may not notice. They have a pebble in their shoe, they stepped on a nail, they cut too deep, the shoes were rubbing others. So that is called loss of protective sensation. And how do we evaluate protective sensation? So now I was talking about evaluating circulation using the ABI. Now I'm talking about sensation. Now this is a monofilament. This delivers 10 grams of linear pressure when it's in a C shape. So what I'll do is I'll say to people, this is what it's going to feel like, and I'll apply it to the back of their hand. And then I'll say, close your eyes, and I'm going to touch your foot in different places. Just say yes when you feel me touching your foot. Now, it's really tempting to say, do you feel it? Do you feel it? Do you feel it? Right? When you're touching their feet, but they will just say yes, yes, yes. So you have to just say, close your eyes and tell me when you feel this sensation that I just demonstrated on the bottom of your feet. Here are the locations we're going to test. We go above or below calluses because they're not going to feel it through a callus. The thing is, if they can't feel this monofilament in one or more location, they have loss of protective sensation, and they are at increased risk for lower extremity ulcerations, complications. Another thing we can use is a tuning fork. I have my tuning fork here. The tuning fork, you put it on the big toe, and you say, tell me when you feel the vibration and tell me when I stop it. If a person can't feel the vibration of the tuning fork starting or stopping, that's also a sign of nerve disease. So this is a sheet in the free resources that I have available for you where you can summarize all the stuff we've talked about. History of foot ulcer, is there ulcer now? Is there deformity? Is there abnormal shape? Temperature, dorsiflexion, ingrown toenails or thick, etc. And it's so easy to put yes or no on all of these. Then we have a documentation of this person's risk, and then it helps us determine what their risk category is. Now, this is very helpful for the team to be informed about this person's risk category and know what action needs to be taken or just surveillance is required. So consider podiatry or vascular specialist referral for those at risk. So here's the risk categories: 0, no loss of protective sensation in feet, and they have good peripheral arterial circulation. 1 is, gosh, they don't really feel the monofilament, or they have pulses that are hard to palpate. Risk 2 is that they have nerve disease and limited circulation or foot deformity. And loss 3 is they have more of these. So risk 3. This then, depending on their risk status, like for 0, we're going to provide ongoing education. For 1, We're going to do routine follow-up every 6 to 12 months and make sure they have proper fitting footwear. For 2, we're going to consider vascular consultation or podiatry and follow up on a regular basis every 3 to 6 months. And of course, if they're risk 3, we're going to really evaluate them closely and get them connected to a foot care specialist. So this is a real nice way to kind of put it in objective terms, what this person needs, where they're at, and what surveillance they require. So, gosh, no DeFEET. We're not going to give in to DeFEET. And I also, in those free resources, have teaching sheets in English and Espanol también that you can download for free and share with your clients. These are not fancy, but they are strategies, how to take care of your feet, what to look for, how to cut your toenails, how to buy shoes that fit you properly. Super basic information that when people read it, they're like, wow, I didn't know there's so much involved in taking care of my feet. I'm like, I know. So, gosh, just a real helpful teaching tool that we offer is a gift to prevent DeFEET of the feet. Okay, question 4. JR has dry cracks in the back of their heel. What is the best action? A, gently scrape the dead skin with a razor. B, apply moisturizer daily. C, walk barefoot to promote healing. Or D, wear white cotton socks. Okay, white cotton socks have reemerged. All right, so JR has cracks in the back of their heel. What should they do? Gently scrape the dead skin with a razor. Apply moisture daily, moisturizer. Walk barefoot to promote healing, or wear white cotton socks. All right. Great job, team. I see the votes coming in. Okay, I'm going to close the poll. Okay, so if JR has dry cracks in the back of the heel, what does that cause from? Well, lots of people with diabetes sweat less from the waist down. So people with diabetes, especially if their blood sugars are elevated, tend to be more dehydrated, and that dehydration can lead to lots of skin issues. So applying moisturizer daily is a big deal. And I'll tell people, because I work with lots of people who have a limited budget. So putting Vaseline on the back of your heel daily and then putting socks on when you go to bed at night can help. Getting udder cream. The dollar store and Walmart have these udder creams that are rich in lanolin, vitamin A, D, and E. And Vaseline intensive care, another option that people can use that's not too pricey. So I really try to work with an individual's budget, and it's really the application of it on a regular basis, especially if they can wear socks at night after they apply it, it can really hold in the moisture. I had one podiatrist recommend a Crisco shortening. So that's another option. But wearing white cotton socks wouldn't really help that. We need to make sure they're hydrated and make sure their skin is hydrated using a moisturizer. So we want people, and this is so basic, y'all, but it's so important. And this can save, these basic instructions can save 50% of amputations. Just looking at your feet daily, encouraging people to look at their feet daily, letting the provider know right away if there's any problems, calluses, drainage, unusual foot odor, and then applying lotion. So that application of lotion daily gives that person the opportunity to touch their feet, look at their feet, smell their feet, be connected with their feet. Wear shoes. Avoid going barefoot to avoid accidental injury. When people do buy shoes, buy them at the end of the day when our feet are most swollen. Make sure there's plenty of room for your toes to wiggle. Break in shoes gradually. And then, gosh, putting your hand in your shoe, especially if a person has nerve disease, to see if there's any rocks or splinters or other critters that could have climbed in there before they put their shoes on. Sometimes that tongue of the shoe is also kind of cattywampus, so really important. Now, standard shoes, we want to encourage broad and square toe box, laces with 3 to 4 eyes per side so we can adjust them. I'm a big fan of Velcro straps, super easy to use. We can adjust them during the day if the feet get swollen. Make sure to have a padded tongue. Make sure there's enough depth. So depth is really important so the feet don't rub on top of the shoes. There's adequate room to accommodate that foot, especially if it's misshapen. And Medicare does approve 1 pair of custom shoes and 3 inserts yearly for people who qualify. And we'll talk about that more. But man, Medicare realizes they're going to pay for a custom shoe because preventing an ulceration and amputation is so much better than just waiting for it to happen and treating it afterward. One way to make sure there's enough room is to have individuals trace their feet. And when they go shoe shopping, put that shoe on top of their foot image and make sure their foot fits inside that shoe, that they don't have to scrunch their toes into a shoe. This can cause a lot of, issues. So this is Medicare Part B that says you get 1 pair of depth and lay shoes and 3 pairs of inserts, or 1 pair of custom molded shoes, including inserts if you can't wear depth and lay shoes because of a foot deformity, and 2 additional pairs of inserts. So you have to have diabetes and you have to have certain conditions in 1 or both feet: amputation, past foot ulcers, calluses, nerve damage, poor circulation, and deformed foot. And you're being treated under a comprehensive diabetes care plan. And Medicare also requires a podiatrist or other qualified doctor prescribes the shoes, and that a doctor or other qualified individual, like a podorthist, orthotist, prosthetist, fits and provides the shoes. So Medicare has some rules around that, but man, it's such a great benefit for those in that 65 years or older category to get custom-made shoes. And the other thing is keeping a track of the temperature that the foot is exposed to. What are different situations that can expose, feet to harm? And I had a gentleman I worked with for a long time, type 1 diabetes, really bad neuropathy on his feet, and he was at a campfire, and he said the only way I knew my foot was burning is I smelled something. And he didn't even know that it was his foot. The skin of his foot was on fire. And I'm saying this because I can't emphasize this enough. For people with nerve disease, they may not feel injury. So we need to be super protective and make sure that they wear, if their feet are cold, people want to warm them up on hot water bottles or put them in hot water. But if they have nerve disease, they don't know how hot that is. So wear warm socks, wear extra blankets, and making sure that no bathroom surgery. So bathroom surgery, we'll talk about in a second. But here's an example of diabetes socks. They're seamless. You don't have to get the fancy kind. As I mentioned, Walmart has them available, and other big stores have them available at a cost that's affordable. Not too tight at calf, good cushion, cotton poly blend, affordable. Yeah. You can also get them on Amazon. No bathroom surgery. So no wire cutters, no razors, no knives. These Dr. Scholl's corn removers have salicylate. They have acid in it. So they will break down this corn, but they will also break down the healthy tissue under the corn and create an environment that's very helpful for bacterial growth. That's, it's not really helpful, but provides bacteria the opportunity to grow. So cutting thick toenails, this is great. I found it on WikiHow. Soak your feet for 10 minutes. We can put some Vaseline on there. You can use this nail file to trim them, or a nail clipper, but we never want to cut the toenails too short. We say don't cut it too close to the quick. And this is a great visualization of that. Don't cut past here, because that can lead to toe injury, ingrown toenails, and other problems. So if a person doesn't have the resources or ability to see a podiatrist, in the meantime, they can utilize these techniques, and maybe that will be helpful. Have a foot doctor trim toenails if you can't see or feel your feet, you can't reach your feet, your toenails are too thick, or your nails are curved over and are growing into the skin. The thing is, we can make a difference, each one of us here. We can assess and coach, we can encourage proper footwear, daily foot inspection, reporting any foot lesions. We can observe and ask questions about that person's lower extremities, and we could refer to healthcare professionals who can evaluate the feet and take further action. and letting the person with diabetes know if there's any foot problems, take off your socks and shoes and show your feet. And a person might say, well, my provider didn't ask me. And I'm like, don't even wait for the provider to ask you. Just have your feet ready to go. If you have your feet ready to go, the provider will be happy to look at them. It's the time it takes to take off the shoes and socks when providers are in a rush that might cause the problem. So just have your feet ready to go. So I want to thank you so much for joining me on this very important topic. I'm thrilled that you were able to join us, whether you're joining us live or recorded. I appreciate your time and your energy to gain this information and to pass it along to your colleagues and to people living with diabetes. Don't forget to check out our free resources. We have a lot of foot care cheat sheets that will be very helpful for your practice and also to share with individuals living with diabetes. We have those in English and Spanish. And I just want to say I really appreciate you being here today. So this is Beverly Tomasian signing off. If you have any questions, I'll hang out after class to answer those. But thanks again so much, everyone. Have a great day.